Hip dislocation, femoral head fractures. Basically, dislocation is posterior. PCL injury is common. Um, there can be classified by Pipkin classification. Pipkin classification is type 1 is infrafoveal, type 2 is suprafoveal, type 3 is with neck fractures, type 4 is with head and acetabular fractures, usually posterior wall fractures. Treatment goal will be restore congruity of the weight bearing portion of the femoral head, restore joint stability, remove incarcerated fragments, and assess femoral neck and acetabular fracture strategies. BO guidelines should be followed: immediate reduction, apply traction in line with deformity, screen to exclude femoral neck fractures, close reduction contraindicated if femoral neck fractures are present, Jacob Bigelow technique, flex, adduct, and internal rotation in traction, recheck sciatic nerve and traction if unstable. Post-reduction CT is important to identify a non-concentric reduction explore to remove entrapped labrum, capsule, osteochondral fragments, and ligamentum teres. Open dissection should be done by hip and pelvic surgeon as per BOA guidelines. Anterior approach is Smith-Peterson approach. Watson-Jones approach is better to visualize isolated fractures or traumatic osteotomy if associated with acetabular fractures. 2 or more 2.7 or 3.5 lag screw can be countersink to avoid head screw permanence. You can add DHS to a type 3 fractures, posterior wall fractures, posterior approach, divide short axon rotators and quadratus 1 centimeter from the incision to protect ascending branch of the medial circumflex femoral artery. This is the main difference from the total hip replacement surgery. You have to avoid ascending branch of medial circumflex femoral artery in this situation. 2. Iliac bundle or stop approach for anterior wall. Toe touch weight bearing creates low joint reactor force than non-weight bearing. Problems with these injuries are AVN, coxa magna, arthritis, and sciatic nerve.